Greetings, welcome to the Brain Gauge channel. And today we're going to talk about drugs and whether or not drugs impact brain gauge scores. And the quick answer, I'll give you the Reader's Digest version. The very quick answer is yes, they do. And, so the more important question is why, I think. But, a lot of people just want to know what happens. And so let's give you a list of the ones that we got experience with. We have actually have data on, or we published on. So, things like THC or marijuana, THC is active ingredient, marijuana or cannabis, alcohol, acute and chronic. Acute just means, you drink and then you test yourself and you drink and you see what the effect is. That's acute. Chronic is you drink all the time and then we see what the effect is. Both of those have impacts, but they're actually different. Heart medications, such as beta blockers, they do have an impact. L-DOPA, such as one of the drugs given Parkinson patients, that has an impact. We've seen cough syrup. That was one of our very first pharmacological publications. Since it's an all nmda receptor antagonist, and you may have heard of other nmda receptor antagonists such as memantine, which is used. It's an FDA approved drug for treating Alzheimer's, and sometimes it helps, sometimes it doesn't. Supplements and nootropics. Nootropics, there are different classifications. Caffeine is considered a nootropic. Supplements, there's a lot of supplements that are sold and people say, oh yeah, they work, but they never test them. One of the more interesting conversations I had over the years, a gentleman called and he was very excited to start using the brain gauge, and and he wanted to test a bunch of people who he's giving us supplements to, and he asked the question. He said, will the brain gauge show that my supplements are working? And my answer was, only if they're working. That was the last I heard of him. Opiates. We've been in a lot of pain studies and we see that what do opiates do? The people that are given opiates feel better for a little while, but it actually makes their scores worse. Treating pain that way is not the best way to improve your brain gauge scores, in my opinion. ADHD medications. We see a lot of this in case studies with clinicians who are treating ADHD patients, and they sort of use the brain gauge to kind of look at, okay, and how much of the medication can we titrate them off? Are they improving? And, so that's kind of an interesting thing. And in particular, as you might guess, their focus score is really impacted. Gabapentin is actually a GABA analog, and it works a little bit like, GABA agonists, which is and this is often prescribed for pain patients. Anxiety meds, such as benzodiazepines or other GABA agonists, those things all have an impact. And generally, you don't want to take these anxiety medications if you don't have anxiety. And by the way, beta blockers are sometimes prescribed as anxiety medications. Anyway, let's sort of now which scores are impacted. If you give enough of these medications, all of them, with and basically the one that's almost always impacted is plasticity. But then the ones that are GABA related, they're going to impact accuracy. What we've seen in Parkinson's patients with and without the drug, their timing perception and their plasticity and their accuracy have problems. So also their TOJ is not necessarily good. Actually, sometimes dopamine actually makes them worse. So caffeine, obviously, that sometimes speeds people up, but we'll talk about that in a minute. So let's move on. One thing to talk about is what are these measures based on? If you start talking about where does the pharmacology come in? How do we know that there are pharmacological effects, and how do we measure them with the brain gauge? Well, all the brain gauge methods were based on patterns of activity in the brain, and that we studied. And here's just to get you in the right frame of mind. Think about this: when you deliver a stimulus, say a vibrating stimulus to the finger, you're getting activation in the brain, and it starts out and it builds. Those patterns don't just happen, they actually build, they're carved out. And that's the way you need to think about it. And what are the mechanisms carving those out? And if you start deleting some of the mechanisms, such as, that can be deleted or blocked with certain drugs, then you're going to start having all kinds of, you're going to get different patterns. The patterns will actually change when you give certain drugs. And that's the whole point. Your perception is going to change and your test scores are going to change. So just to visualize this a little better, think about, basically your fingers are connected to this circuit, the circuit in the brain. And, you have upper cortical layers up here and lower cortical layers like here. This looks a little bit more normal. Now let's pretend this was your brain, and you're recording from it. And this is in somatosensory cortex. That's what S1. It's not SI, it's S1 cortex. And basically, we deliver a stimulus here and a stimulus here. And let's say, one stimulus is a little bit larger than the other, and you're trying to figure out which one's larger. Well, if you deliver it just really briefly, and one's just a tiny bit larger, then you're really going to have trouble telling the difference. Let's think of it in terms of 40 milliseconds, because we're delivering a 25 hertz stimulus. So every 40 milliseconds, you get another cycle. And each 40 milliseconds, you get a little better at it. Well, why is that? So why is the important question? Well, let's say that one is slightly larger than the other, and activity is the output of this particular finger representation, the output. Well, it's slightly larger on the first cycle. What happens? Well, if it's slightly larger, it's going to come over here and it's going to try to turn down this digit. And, this one's slightly smaller. And it's going to try to also turn down that one, but that's on the first cycle. Now, the other thing that's going on is that when it comes in, when the stimulus comes in, it starts to activate things in the upper cortical layers like nmda receptors, and these are voltage dependent. That means the first stimulus doesn't have much effect, but the next stimulus got a little more of effect, and that those voltage dependent devices start turning this off even more. And this is starting to get weaker because it's getting turned off by this one. So this is turning this off, and this is trying to turn it off, but its receptors, they start getting deactivated because this one's getting it turned off. So just keep thinking every 40 milliseconds, and every 40 milliseconds after that, this gets a little bit more prominent. It's almost exponential. And the difference is each time the activity coming out of this one will be much stronger than the activity coming out of that one. So if there's something wrong with the nmda receptors, then the long-term effects of those things don't work, and you don't get the plasticity. That's partly what plasticity does. Okay, what else does the nmda receptor do? Remember, we're talking about drugs, so we want to know what that nmda receptor does. One thing it does is it screws up variability. And what I mean by that is, let's consider this. Look over here on this right-hand side. What I've done is posted a recording from the periphery. This is actually, these are spike trains. And that just means there's a spike from a nerve with every sinusoid. And that's in the skin. That's the fidelity of the skin. And what you're receiving in the skin is transmitted through these nerves in the periphery. And so this looks extremely regular, not a lot of variability. Over here, there's a whole lot of variability. And this is from the same stimulus. So here, this is the vibration just like you get with the brain gauge. And over here, well, that doesn't look anything like it. But there's a lot of information in here. Now, you dose up the cortex with an nmda receptor antagonist, well, it turns down excitability, all right? And so all of a sudden it looks more and more like this. So variability actually goes down. And so the way things change with the way different drugs that impact different disorders is, well, it's different. Depends on whether they have hyperexcitability or hypo inhibition or whatever. It just depends. But basically, that's the idea to think about it, is it turns down variability and it turns down plasticity. You get very different patterns involving when you don't have NMDA receptors present. So that was one of the first things we tested, because we've been testing it for a long time. And we gave a little bit of cough syrup to a group of people and did some measures. And we found out now these measures are related to accuracy, the accuracy score. These measures are related to plasticity. And the people, look, you don't see a whole lot of difference in the accuracy score because it's not quite as dependent on NMDA receptor as the plasticity score. The plasticity score is really dependent on NMDA receptor. And so look at the difference here. And that's just taking, like I said, it's just taking cough syrup, which, yes, it does make you feel goofy, but we measured the goofy. It's your plasticity is going down. So anyway, that's basically what's going on. Everybody else had a blind placebo, and so you basically, there's no effect on the controls, but you see just a tiny effect in accuracy, big effect in plasticity. And that's from NMDA receptor block. Accuracy, more GABA related. We'll get to that in a second. Here we are. We're going to get to it right now. So let's talk about lateral inhibition. When you've got two things side by side and they're fighting for each other, what's going on? Well, let's think in terms of excitation. Wherever you have excitation in the brain, you have inhibition surrounding it. And just like here's a picture of that activity, called lateral inhibition. Everything's turned off surrounding excitation. And if you start doing experiments where you turn off that inhibition, like over here, we're turning off this is before we turn off the inhibition. And this is after we turn off just a little bit of inhibition. You don't turn off a lot in these experiments. You just turn off a little bit. Otherwise, you get a seizure. Over here in this crappy looking image, which, I took a photograph of my dissertation. This was pre-digital recording, So basically, this is an image of what we got out of an experiment where you see this whole area is elevated. And just to give you an idea of how much it's elevated, this is the activity level of this area here. And there's really, the distribution you see is really kind of Gaussian. But over here, it's much more split, much more diverse. You have actually two distributions. You have on and off. So over here, you've lost all the off. And what it should look like is something like this, where you see a whole bunch of peaks and valleys surrounding that pattern. So you see a bunch of patterns here, but over here with that little bit of bicuculline, which turns everything off, you don't have the same pattern, and you don't have that variability that you see over here. So that's really important. Variability is information. So it's a little bit different, but it's also not carving things out. Now, what do we have over here? This is classic amplitude discrimination task. Activate these two places in the brain, and you get two distinct areas. See how distinct that is in that histogram? And activate these two places here. It's actually the exact same image. It's just now the inhibition's turned off. You can't tell the difference. So accuracy is going to be shot. So anyway, accuracy is going to get turned down with anything GABA related. What uses GABA? Well, stress and anxiety drugs, like we mentioned, anti-anxiolytics, those all use a lot. They're mostly based on GABA agonists. Same for like a lot of treatments for depression are GABA agonists. GABA has this very calming effect on people. And so if you have super high excitability, one way to turn it down is with that GABA agonist. So anyway, those are some of the main drugs. Is the GABA agonist, which enhances inhibition and gives a calming effect and turns things off that way. The NMDA receptor antagonist, which is turning off the effects of excitation, turning off the effects of glutamate. Okay, and let's look at a couple of examples, which you may have seen this already, but we'll look at it with a little different outlook. Okay, so keep in mind, let's just look at the chronic case first. Keep in mind that alcohol is a GABA agonist. And if you drink and drink and drink every day, your body quits making and manufacturing GABA. Well, if you quit manufacturing that GABA, well, what happens when you quit drinking? Then you don't have enough GABA. All of a sudden, both your accuracy score and your plasticity score are going to be bad. That's the case right here. These are alcohol subjects right before they started treatment. After treatment, this was after 12 weeks of treatment, their accuracy score is better, and their plasticity score is better. So keep in mind, this is a little different than what you're used to. Smaller numbers here, better for accuracy. Bigger numbers here, better for plasticity. So that score there, very bad. Now, acute, that's just doing an experiment where you take measures and you measure before and after drinking, or before and after while drinking and later, and you take blood alcohol content, and you see that it does impact both accuracy and plasticity, but it doesn't seem to impact it quite as badly as the chronic case. And then over here, we've talked about this before, but if you weren't aware, this is what happened. This is also effective drinking 60 drinks per month. If you're 18 to 22 and you drink a lot, then this is going to impact your plasticity score. This was very specific, showed a lot of specificity in this study, because these were 18 to 22-year-olds who were drinking, a different number of drinks per month, showed a big decrease in their plasticity. Interestingly enough, their accuracy did not get worse. None of their other scores got worse, just the plasticity. So that's kind of interesting to think about. But obviously their learning is not optimized when they're in college and they're supposed to be studying and they're drinking this much. Anyway, let's see what else we got. That's GABA and nmda. That is impacted by GABA or nmda receptors. Well, these are controls. This is all looking at improved plasticity in this direction. That's your score for plasticity. Controls level, concussion is before and after recovery. Vulvodynia, or a pain, particular pain type of pain, is before and after treatment. In this case, the treatment was gabapentin. Gabapentin is a GABA analog, and so it does some of the same. It acts the same way, or acts in a very similar fashion in terms of these scores. Obviously, plasticity improved. Alcoholism. This was before and after treatment. The treatment was with baclofen, a GABA B agonist. Autism. This was this is an interesting study, and this is where IRB screwed things up. But basically, we were doing our study, and then we had some crossover from another study where we were seeing patients, we were seeing individuals with autism and testing them here. And then these other people, the same people, were in another study, and that study, they were given SSRIs. And those SSRIs have a downstream effect on GABA, improving GABA. But basically, what we saw was that on these patients or individuals who were receiving that treatment, they got a lot better with their scores. And once we contacted the people and figured it out, what was going on, because we'd see these people and we'd see them 6 months later and they're all of a sudden better. And we contacted the people doing the study, got kind of excited. This would be a great study, except the people that were doing the study decided to discontinue it because they were not getting any good results. See, their results, they were looking at the results with MRI, or a method of imaging, which has, compared to our method, pretty crappy resolution. They weren't looking at the right way. If you're going to look at something that's sensitive to brain function, MRIs ain't the way to go. So anyway, let's see what's next. Okay, quickly review plasticity metrics. As we mentioned before, lower numbers here for accuracy, they stay constant. Higher numbers here for plasticity, they stay constant with age. And that's all true unless something goes wrong. And so we went and tested people that were over the age of 65 in an assisted care facility, and the data was all over the place until we sorted it by who was on medication and who was not. And it turned out that the medication was beta blockers. So here's what most people look like who are medicated, and these are the people with no medication. So there was some kind of an effect, small effect on accuracy. Basically, with no medication, smaller numbers are better here. So they were a little better on their accuracy score. But on their plasticity metric, no medication, this much bigger. So what we're looking at is difference between here and here. We saw a huge impact on their plasticity when they were on beta blockers. Now, is that cause and effect? I don't know, but don't believe it. When you go and you read something that says that beta blockers do not affect brain function, you need to find another paper, because I just did a cursory glance at the literature, and some people still say that, and they're really not qualified to say it. And, you know, if you have somebody telling you that, just challenge them. Anyway, there's plenty of studies other than ours that look at the effects of beta blockers on brain function. So anyway, let's go to next. Let's see what else we got. Recreational drug use. That's always a fun topic. And this says recently an Olympic athlete. Okay, that was a few years ago because it was an Olympic athlete. It was probably 1 or 2 Olympics ago. He was suspended from competition because he used THC and or it was, you know, marijuana was detected, and they said that enhanced reaction time. Guess what? It does not enhance reaction time. In our studies, we found that people who regularly use THC, people who use it a lot, heavy users, you don't see any effect. They're 20% lower to start with. Okay, they're 20% worse to start with. People that use recreational use of THC, yeah, they get worse when they take THC. And people who never use THC and take it, then they get 20% worse. The bottom line, the interesting thing was, the most interesting thing is that the heavy users thought that they were better than everyone else. But anyway, it does, you know, through across a bunch of different studies, we found that focus, accuracy, and TOJ are impacted by cannabis. But you know, take it with a grain of salt, however you want to take it. Anyway, one last thing. Nootropics. I mentioned my story about supplements. Nootropic is the world's oldest, caffeine is the world's oldest nootropic. And it does have a tuning curve. And, you know, I'm just got a standard tuning curve up here, and I've got dosimetry on the bottom line, score on this. That just means your scores are better when they go up. This is neat. Dosimetry means you're taking more of a dose. So let's think about it in terms of caffeine. Caffeine, let's say, and this list being, say, reaction time. Reaction time is a classic study, and don't let people tell you it's never been studied. I mean, I read a paper that's not too old that said they were the first people to look at the effect of caffeine on reaction time. The first paper on that I know of was 1934, and that other paper was done in the last several years. So, you know, you always got to do your homework. Anyway, looking at the dosimetry here, let's consider take a little bit of caffeine right after you get up, and maybe that makes your score get a little better. Take a little more, score gets a little better. But then you get carried away and you drink 8 espressos and you start getting the shakes. Your scores are going to get worse. Okay, so it's really important to figure out what your optimum tuning curve is and measure it. So anyway, that's it for the drug talk for today. It's a Friday afternoon. Hope you enjoyed it, and have a great weekend if you're watching this now, or send some questions whenever you're so inclined, and I'll be glad to try to answer.